Speaker for today. Today we have Dr. Tanya Gure, is a professor of internal medicine and geriatrics. She serves as the section chief of geriatrics, my goodness, since 2013. In addition to program leadership, she works as a clinician in the geriatrics outpatient clinic at Upper Arlington and as a hospital-based consultant. So please join me in welcoming Dr. Gure.
Can you all hear me okay? All right, good afternoon. I'm really just delighted to be here. I really appreciate the invitation. I love talking about this topic, so it'll be fun to engage with a new audience and community to learn more about what things concern you as you're progressing in your life with health and wellness. I also just wanted to thank the department of the Buckeye Wellness program. They have been, I've been the recipient of many of their wonderful programs over the years as faculty, especially during COVID. I was able to participate in some online activities for wellness, which was very helpful. So I'm glad to give back, and it's really nice to be with you. So I'm going to talk about healthy aging from probably what I would say more of an aerial perspective. You know, seniors are a very complex group of individuals. I always say there's no monolith within the senior community. And so it's hard to talk about common elements that touch everybody, but I'll try to focus on those topics that I think come up the most in my practice. And we'll have some time for questions, you know, in case there are other topics that I didn't touch on. I also love to get some feedback from you all. So the main plan for this talk is to go through kind of two main top content areas. The first is to talk about normal aging and what that looks like from a physiologic perspective. I'll go over some of the main organs. I'm an internist, so you know I'm not going to spend a lot of time on skin and eyes, but nevertheless, these are common conditions that that folks develop as they get older. There's a normal aging process that I'll try to describe for those various disease systems, health systems, and we'll talk about that some in terms of implications for health. And then the second part of my talk will be focused on preventive health. And again, I'll be focusing on some of the most common areas for preventive discussion. But again, these may not be exactly germane to you, but hopefully you'll find some resonance and maybe think about a future plan for yourself. So the normal aging process, I'll start by talking about that first. And I found that when I talk about this sometimes within groups, that people get a little bit down thinking about, wow, aging is no joke. There's a lot of changes that are happening. It can make you feel a little bit pessimistic, a little bit sad. But I wanted you to keep in mind that these things are happening at a micro level, but they can still, they're important. They have implications for your health as you progress in your life. But you can still have that glow and that radiance like this beautiful woman. And it's important to keep in mind that there are ways that you can optimize your health that can allow you to live your best life no matter what decade of life you're in. So let's start with the cardiovascular system. In normal aging, the cardiovascular system goes through some fairly significant changes. Again, these are all probably what I would say subclinical processes, but it really does depend on the degree of exercise that you've done for a lot of your life, and whether you have the existence of chronic medical conditions that might have some direct impact on the aging process of the heart. So for example, if you have hypertension, that might affect how your heart physiology changes as you get older. But the maximum target heart rate tends to decline. And for those of you that are into fitness, you might notice that your target heart rate changes based on your age. And so it's a nice little subtraction problem. And you can see what your max heart rate is. Well, decade to decade, that changes. And you can see those tables if you ever are interested in those kinds of fitness programs, you can see that. Heart cells enlarge, and there's also muscle stiffening that can happen with the heart. The valves can thicken with some calcium deposits that can occur. And there can be mild cardiac rhythm changes that happen with aging. In the circulatory system, which is a part of the cardiovascular system, blood vessels lose their elasticity. They can narrow to some extent. The heart, as a result, needs to work harder to circulate blood because there's more resistance. And the capillaries become more fragile. Vein valves can become less functional. So the implications of normal aging in the cardiovascular system is that blood pressure will increase. Now, notice I didn't say hypertension develops. I said blood pressure will increase with aging. And there can be a decrease in exercise tolerance that happens because of that. So what you might notice is that you may feel more fatigued or short of breath with routine activity. Orthostatic hypotension is more likely to occur. This is a sudden change in blood pressure or heart rate with positional changes from lying or sitting to standing. Pulses in the lower extremities can diminish, and there can also be more pooling in the lower extremities related to those vein valves becoming less functional, and so lower extremity swelling can be more common. In the genitourinary system or the renal system, there are some changes that are also well described. There is wide variation in kidney function. Of course, as I mentioned before, it depends on how healthy you've been for all of your life. But generally speaking, we know that the kidney size does change. There can be decrease in blood flow to the kidney, and there can be a decrease in kidney cells called the glomeruli, about 30% on average. And there's also a decrease in secretion in the tubules. These are the functional part of the kidney that helps with filtration. And there's also some difficulty with diluting and concentrating urine that happens. And this is all what I would describe as subclinical changes. In the genitourinary system, there can be gender differences in what you might see with aging, but let's start with the bladder. There could be some decrease in nerve impulse to the bladder, making that muscle contractility a little bit more diminished. Also in peri and postmenopausal women, just due to the lack of estrogen, the urethra can shorten and the urethral closure pressure will reduce. In men, prostate enlargement is more common with aging, and there can be higher post-void residual or even obstruction when there's a clinical diagnosis of hypertrophy. And so the implications of normal aging in an older adult from the genitourinary and renal perspective is that you can have decreased urinary flow and increased susceptibility to kidney injury. So think about medicines that might affect your kidney function because you already have a diminished number of glomeruli that can increase the risk of an acute kidney injury, a toxic accumulation of renally cleared medications, and also urine leakage or incontinence can happen both at the bladder and also with urethral changes. And also in women, we see that urinary tract infections can be more common. In the musculoskeletal system, this is also a highly variable system with respect to aging. So muscle or muscle mass is hugely variable. Looking around the room, I can see all degrees of muscle mass, muscle bulk. Of course, we also know there's even higher levels of muscle bulk that people can get to even when they're older. But there is a decline that happens in muscle mass with advanced age, especially over the age of 80. And there could be more fat and connective tissue that deposits in those muscles with prior injuries, say from tendinopathy or strain. That muscle can become less healthy. And at the bone level, we know that cortical thickening can decline with aging. There can also be mineral loss in the bone, a leaching process. And on average, decline of bone density is about 0.5% per year. That is in healthy adults. And of course, it could be more rapid in women due to the changes in estrogen after menopause. The musculoskeletal system is also made up of joints, of course. And so we know that musculoskeletal issues are very common as people get older. And cartilage thinning can happen. Also, calcium deposits in the cartilage that can cause more issues with pain. And imbalance in the repair and destructive mechanisms from strain or overuse that joint tends to have more difficulty repairing. And so the implications of the musculoskeletal system with normal aging is that that walking speed can slow down because of that change in muscle mass. Muscle loss tends to be more disproportionate. It can be more in the legs, less in the arms. And there's longer recovery time after an injury or a strain, or even just a workout. You have to spend more time letting that body, those muscles and those joints heal. And there also is an increased risk of fracture, ligamentous strain, or muscle tear that can happen due to some of the changes in the muscle quality. Brain aging is a very important part of older adult health that we spend a lot of time on. And I get a lot of questions about what's considered to be normal and what's considered to be abnormal. In common sort of aging science, we know that brain volume can change as patients get older, particularly after the age of 65. We know that there's changes that happen in the frontal and temporal lobes. That's the front of the brain and the side. And with normal aging, typically we see that there's a slowdown in new learning. There can be a mild decline in memory, but it should not be anything that's clinically significant. There's more, that may mean that there's more effort and time in needing to recall new information. For example, being forgetful around some content that was just learned, but it should eventually be retrievable. There also is preserved ability to recognize familiar objects and faces over a lifetime. There's a mild decrease in attention span, some decline in language abilities in late life, and also a mild decline in executive function. This is the domain of cognition that's involved in advanced planning coordination activities. And so I went through normal aging, not for the faint of heart, as we discussed, but still capable of living your best life, even with these processes ongoing. And I like to just talk about that because it helps us to understand how we focus our clinical evaluations in patients as they advance through decades of life. And as a geriatrician, I typically start seeing patients around the age of 65, but older age is really considered to be 60 plus or 55 plus. So we'll talk about preventive health first and what that means in terms of the continuity. So preventive health is a very important concept that primary doctors, primary providers, I should say, spend a lot of time on. And hopefully you've all been tapping into your primary care providers over your time as a Buckeye. And by the time you get to the point where you're considering retiring, or if you're in late enough life that you really are thinking about some changes in your life, hopefully you have had enough primary care to really understand what your salient health issues are and how to move forward with your prevention. So some of the things that I'll be talking about are things that you probably have done many times already in your life, but there may be some things also that are really new with older age that I'll try to bring up as well. So we're going to talk about cancer screening, diet, coronary artery disease, risk stratification, and primary prevention for heart disease and stroke, immunizations, bone density, diabetes screening, and some common health topics that often come up during my practice as a geriatrician. So in general, the way that we think about older adult health maintenance is kind of with, as I said, an aerial view of population health. So this really describes what has been conveyed through our societal recommendations, the guidelines that exist through different healthcare entities like the Centers for Disease Control, the USPSTF, which is the United States Preventive Services Task Force, the American Cancer Society. There are a lot of societies that are related to particular organ systems like Lung Society, et cetera. And so they have guidelines that are often communicated and updated based on the evidence and the science that's been generated over the full extent of a condition. And so we use that in order to determine what are the appropriate things to consider in our evaluations of patients. So that really drives a lot of what primary care providers do when we're talking about prevention. We're thinking about what are the most common things that may occur in your life and how we can really approach recommendations around screening for that. So invariably, when you're dealing with a population concept, that doesn't always directly sort of manifest in what that individual wants. So we reconcile the population-based sort of guidelines with what is the individual preference, goal, et cetera. And there's lots of things you take into consideration. I mean, just as diverse as this room is, you can imagine what it's like being in a primary care practice and having to deal with thousands of patients who have different kinds of goals and the way that they want to approach things. It can be everything from religious preferences, it can be anything from being more sort of wanting to take a more conservative approach, not believing in wanting to expend a lot of energy on those kinds of approaches to preventive health. It can be a whole range of things. Also, sometimes it is related to just not having enough information and trying to really convey to the patient what is known and how to sort of fill in knowledge gaps. But when you kind of get on the same page about the value of a particular intervention around prevention, you really want to try to gauge what are the goals of that patient. What are their short-term goals? What are their medium-term goals? What are their long-term goals? Now, as a geriatrician, sometimes I hear patients say, I want to live, I want to make the world record for the oldest human. Those are a little harder to sort of encapsulate in terms of a healthcare goal. But then sometimes a patient can be very specific. I want to be able to walk and spend time in my line dancing class every week, or I want to be able to see my great-grandchild born. And so this really helps to sort of, for me, to really sort of set the goal around how to approach screening when I know that that person has long-term goals for longevity, or if they're really more focused on short-term goals, then we try to sort of put that in context too. The other thing that's really important, although this group may not have much that they're considering in this regard, but you may have loved ones who are older. Sometimes we do actually talk about limiting screening based on life expectancy if there's advanced illness, if there's a lot of kind of conditions, if there's a concern that someone is not going to be able to live beyond a certain time period where they would not benefit from the modality or the preventive task that we're discussing, then it is important to take that into consideration. And so cancer screening is one big part of health maintenance, and I'll spend some time going over the general guidelines for this. So colon cancer screening is one area that you probably know a lot about, but I'll try to go through it in terms of presenting what are considered to be the invasive modalities, what are the non-invasive modalities, and some I won't spend too much time talking about when screening starts because that's not really the purpose of my presentation. But by the time you have seen a healthcare provider when you're a middle age or older age, typically we anticipate that you have done some screening in this regard beforehand because the guidelines have been changing. I think now the start age is about 45 for colon cancer screening. So invasive modalities include modalities that would require a prep, would require potentially anesthesia depending on the type of test that's done. And those include the colonoscopy, the CT colonography, capsule colonoscopy, and flexible sigmoidoscopy. I kind of have them listed in terms of what is the most common. And flex sig is kind of less common these days because the extent of the colon evaluation is much shorter with that and can potentially leave additional concerns about missing polyps in the colon. Non-invasive modalities are also present and have existed for a long time, but there's been some advancement in the products that are available there. So I thought I'd spend a little time on that. You may have heard of the FOBT, that's the fecal occult blood test. That's typically done annually. It's done less often now because it has a very high false negative rate. It really tests frank blood or even, well, maybe even some occult blood, but it has to be significant enough and at the timing of the providing the stool specimen that you can identify whether there's blood present. The fecal immunochemical test is another blood test in the stool that can be done that has a little bit more sensitivity, a little higher predictive power. But typically that needs to be done fairly frequently, like every year for the fecal occult blood test. For the FIT, that typically is done in combination with the Cologuard. I don't know if you've all heard of the Cologuard. That's the fecal DNA test. And that has a marker for the most common type of colon cancer, adenocarcinoma. So between the FIT test and the fecal DNA, you get a very high sensitivity and specificity with that particular screening modality. And some people choose to go with a non-invasive approach. It's not easy to kind of embark on colonoscopies, particularly if you're average risk. And so we try to offer these potentially as options for screening, depending on preference, as I said before. Screening typically stops at 75 to 80 years old, depending on the guideline. Now let's talk about mammography. That's a more gender specific, although men do get breast cancer, that tends to be less common. So at this point, the guidelines suggest annual screening, and that age start really depends on your familial risk, but on average, it's about 45. And screening is individualized beyond age 75. Guidelines typically have a screening cutoff between 75 and 80. There's a lot of variation depending on the guidelines. Some don't even have a recommendation around stopping screening. So you're going to have to really communicate with your primary provider about that. And typically what I say is that decision should really be based on preference and also life expectancy. If it's less than 10 years, there's probably not a lot of benefit in doing additional mammography after age 80, and also the extent of chronic conditions. Because remember, the point of screening is to identify, if you're identifying something that is cancerous, that patient has to be able to undergo all the treatment and testing that's necessary, and it may not be feasible if someone is quite sick. Cervical and prostate screening. So cervical cancer, of course, is a real issue in women. By the time someone is older, it's a little less of a lower incidence. Although there are patients that I've seen that have not had cervical cancer screening. So obviously the risk is a little higher for folks who've never had cervical cancer screening. But the interval of screening really is based on the cytology. That's the pap smear. So if you have a high grade or a change in your normal cytology, the gynecologist or the primary provider will give you guidance on how to approach screening in that case. It can be anywhere from annual to every 3 years, depending on what's found. And screening can be stopped after age 65 if you've had a hysterectomy with removal of the cervix, and if there's been 3 consecutive negative pap smears within 5 years. In prostate cancer screening, that plan is really individualized based on patient preference. There are some guidelines that suggest for certain high-risk groups like African American men, screening to start at age 45. Okay, so we covered cancer screening. Now we're going to talk about health maintenance related to immunization. This is a topic that is probably part of the zeitgeist these days. With COVID, everyone's talking about it. I have more informed discussions about vaccinations than I ever did with my patients in the clinic, because everybody understands how these vaccines are working, what the interval schedules are. So it's actually been very interesting. So as you know, that influenza vaccination is important, obviously, as workers within a large institution like this. I don't know how many of you are healthcare workers, but we're amongst that group that has to get these kinds of vaccines. And if there's a high dose vaccine that's really specific for seniors and increases the immunogenicity related to the vaccine, there's also a quadrivalent vaccine for patients who are less than 65 years of age. Either vaccine is appropriate to get. I often get this question, Dr. Gure, they're out of high dose vaccine. What should I do? And I say, get the quadrivalent, because you're going to get good protection with that. It's just a little bit more of a boost with the high dose. Pneumococcal is an important vaccine for seniors over the age of 65. You may have gotten it earlier. It really depends on your medical condition history. I'm one of those folks who have gotten it because I have a history of asthma. So it really depends on your medical history and what warrants getting it sooner. COVID, of course, is an important part of our vaccine schedule now, and I think that'll be a part of our seasonal fall vaccinations for a long time. Zoster recombinant adjuvanted vaccine, that is the vaccine that helps to reduce the risk of shingles, and it is recommended after age 50. It's a 2-shot deal with about 6 months between the two, a maximum of 6 months between the two in the series. And it also really substantially reduces the risk of post-herpetic neuralgia. So it has been a really important vaccine in reducing shingles and complications for that, pain syndromes, et cetera. Of course, there are many other vaccines that are relevant and important, but it really varies depending on risk and health conditions, so I won't go over those right now. Bone density screening. This concept is really something that's a part of women's health more than men's, but I will cover some aspects of men's health where this is concerned. As I said, with normal aging, you can have cortical thinning. You can have bone-related loss that's happening at 0.5% every year. Of course, that's more accelerated for women. Hence, that's why bone density screening has become such an important part of health maintenance for women. Depending on a woman's diet and what kinds of other health behaviors that woman may have had in her earlier life, that can also precipitate a higher risk of osteoporosis. So screening guidelines really vary depending on that factor. So if you have at least one risk factor related to alcohol, heavy alcohol use, a family history of hip fracture, cigarette smoking, low body weight, any estrogen blocking medications. So these are the kinds of medicines that are used when someone has breast cancer that's hormones sensitive. They might be on an estrogen blocker. So that increases the risk. Steroid use for a variety of different reasons, and secondary osteoporosis from other endocrinopathies. And so if you have a risk of that, screening should start earlier. If you don't, then 65 or older is kind of the scheduled start for bone density screening. And then subsequently, depending on what that bone mineral density score shows, we'll recommend, every 2 years to every 5 years screening, depending on the findings. In men, the guidelines are very unclear about bone density screening. And so we tend to focus on high-risk groups. So in part of your intake and evaluation, we're asking about whether you've ever been on steroid therapy. If you're actively on it, that may be something that your provider may plan later in terms of screening. If you've had a history of prior low trauma fractures, so that's something that happens kind of at a low velocity, for example, a tripping injury or a fall from standing, rather than something that's related to an accident from a vehicle or being in the middle of a sport or at a higher velocity. Hyperthyroidism is another condition that in men and women, that's one of the secondary osteoporosis etiologies that I was kind of alluding to in the women's discussion. And then androgen deprivation therapy. So this is a hormone blocking medication for gentlemen who have prostate cancer. And so bone density will diminish and decline more rapidly when there's less testosterone acting on the bone. Let me take a little water swig. So in nutritional counseling, this is one of those healthcare topics that we spend a little time on. And it is, I think, an important area. Patients tend to be very concerned about it, want to have that feedback on how they're doing. Obviously, there are vital signs that we evaluate on the clinical visit that can help us to know something about your nutritional status based on weight. So weight and BMI are two of the main metrics in the vital signs that we're calculating. And we'll be looking at those trends. So I love to go in IHIS and I love to use that synopsis tab and look at the chart of the weights over the last year or 2 years. It gives me an understanding of where that person has been and whether there have been any precipitous changes. And so that is critical. And then also I am looking for, if there has been weight loss, wanting to know whether that was intentional or unintentional. That tends to trigger additional concerns and ways that I can approach evaluating that patient in front of me. And then also I'm asking about barriers to sufficient nutrition. So we know a lot about social determinants of health. Very important to think about whether or not patients have access to food, whether or not they ever have times when they don't have food in their home. It never hurts to ask, and I've never had anyone respond negatively to my questions in that regard. In addition, it's important to think about dental health and whether that affects the quality and the types of food that a patient can have. And so all of those things go into sort of the overarching assessment. And then if I identify that that person is undernourished or overnourished, then I can sort of approach that from different ways. One is to get a sense of their current diet and what dietary nutritional resources we may want to recommend. If there's a swallowing issue, obviously there may be a need to think about another route for nutrition. But if it's just an issue of not being able to get enough intake in, sometimes we think about nutritional supplements like Ensure or Boost. Also, ways to kind of enhance diet at home with food prepared by family and loved ones. I found that particularly when there's a change in the life status of an older adult, with if a spouse passes away or living alone or more alone, that nutritional intake can really vary in those circumstances. So it's good to talk about those supports. And then of course we have amazing dietary and nutritional resources here at Ohio State. And so referring patients within the clinical services is also can be very high impact. Weight management for patients who are overnourished or overweight based on BMI, we can determine what the level of obesity is that a person has and provide direct guidance on ways to really improve weight management. As you know, there are medications that have really been in the news lately related to weight loss that can be discussed depending on where the person sort of is in terms of their status of being overweight. And then, considering whether there are other risk factors or concerns that a patient couldn't tolerate it. I also typically in sort of the scope of nutritional counseling, we'll talk about vitamin supplementation. That's important. And I think multivitamins are not a bad idea. With iron are typically good because diet does tend to vary over time and probably gets a little less diverse, particularly for older patients who may have not be cooking for themselves, et cetera. Okay, on the health maintenance, also, we do a really careful evaluation of cardiovascular and stroke risk. This is the number one killer of U.S. adults. And so that is an important part of our evaluation that we're doing. And there's even about, sort of an assessment that's going on in the background of your clinical visits, whether it's in the OSU system or outside, looking at your cardiovascular risk. So that risk assessment is based on kind of what we call a population base. This is that, again, that reference I make to population-based assessment of risk. It's a lipid panel, so the LDL and HDL is specifically in that calculator. The systolic blood pressure, whether or not a person has diabetes, whether they're on blood pressure medication, and we calculate that 10-year risk of heart attack or stroke based on that, and we can stratify someone as low risk, moderate, or high risk based on that. That cut point is 7.5%. And so if you're at 7.5% or lower, we are advising you about how to further modify your cardiovascular risk score based on lifestyle modification. So that's exercise and diet. If it's greater than 7.5%, that's where potentially a statin medication can be used at a low dose intensity to further reduce your cardiovascular risk. Clinical evaluations with diabetes screen, that's part of your YP4H evaluation. The A1C is checked, and we put a lot of time and attention to that because pre-diabetes really increases in prevalence with age and is associated with a higher likelihood of becoming diabetic. And that A1C cut point is very helpful for us in knowing what your average blood sugar is at any given time. And we can know whether a person's normal, if it's less than 5.7, or if it's between 5.7 and 6.4, that's the pre-diabetic range. If you are diabetic, your A1C is typically greater than or equal to 6.5%, and that corresponds with the average blood glucose of 140. So after we've done all of these clinical assessments, I think it's critically important to talk about ways to optimize health. And so exercise is a really big part of the time that I spend talking to communities like yourself and older adults within my clinic visit. And the key point I just want you to take away from this is to balance your portfolio however you can do it. So exercise is made up of really important domains that you can't really do one without the other. and have a well-rounded physical health. So aerobic conditioning, strength training, flexibility, and balance are all parts of exercise. And so I'll often, as I'm talking to patients about what they do for exercise, say, okay, your portfolio looks good, or you're missing some areas that you need to work on to keep your physical health well. So aerobic exercise is one component of exercise, and the recommendations are for moderate intensity exercise, 20 minutes, about 5 days a week. And that can be exercise that's at the level of, I don't know if any of you do like workout-based heart rate targeting, but that's like zone 1, zone 2. It's a level of activity where you can still talk, maybe sing your favorite song. I love to sing, We Rule the World, Girls. I can sing that when I'm at zone 1, zone 2 really well, Beyonce song. And at vigorous levels of physical activity, the recommendation is 20 minutes, 3 more days a week. That's the level where you really don't want to have too much conversation. You don't really want to talk. You can say your day's good, but beyond that, it's going to be hard to really get through a full discussion. And sometimes I find myself saying, hey, I'm working out. I'll get back to you later about this when people come up to talk to me while I'm on my machine or on the treadmill. And then the goal is to really set goals around to exceed the minimum. So I often tell, it's common, I'll ask patients, so what do you do for exercise? They say, oh, I love to get on my stationary bike. And I say, what do you usually do when you're on a stationary bike? Oh, I read, or, I watch TV. And that generally tells me you're not challenging yourself enough. You need to dial it up, increase the resistance, because if you can take your attention completely somewhere else, you're probably just going through the motions a little more than you need to. So keep pushing yourself to get beyond that minimum, set goals. Strength training is another critical part of exercise portfolio. I see a flex here. Yes, I love to flex. And there are different types of strength training that you can do. Resistive bands, weights, isometrics. These are basically movements of the muscle without any kind of load on there. And you can target 8 to 10 muscle groups at any one workout. I would suggest doing that over 2 days in the week, trying to avoid having back-to-back so that you don't end up with a muscle injury. This was a study that was recently published looking at the types of exercise that are most effective in lowering blood pressure. And so they did a meta-analysis or a systematic review looking at a very large number of studies that have tried to answer some of these questions, looking at blood pressure differences with different types of exercise. And there were about 270 studies in this. And so I thought I'd point out a couple of things. So the general take home is that all exercise lowers blood pressure, but I thought I love the idea of sharing this with you because I think it sort of dispels that myth that you have to really go hard in order to really achieve some level of cardiovascular health. So aerobic exercise in this pooled analysis was walking, cycling, and running. You can see that on average, there's about 2 to 8 millimeters of mercury of reduction in systolic blood pressure. Dynamic resistive training, that's kind of like weights. So like if you're on a circuit of weights or you're using dumbbells or a barbell, you get some blood pressure lowering with that. Combined training is a combination of aerobics with dynamic resistance. You get a little bit more of a bump there. And high intensity interval training, that's HIIT. There's different names of them around. I don't know what sounds familiar to you, but these are interval training at high levels. That's kind of hitting more of that vigorous heart rate goal that I was talking about, where you don't want to talk to anybody, just want to be focused on getting your work in. And that results in a good level of blood pressure lowering as well. But the largest gain was in isometric exercise training. And isometric exercise training does not involve high vigorous heart rate targets. This is isometric hand grips. That's using a gripper. Even when you're using a barbell, you can do some hand grip. Isometric leg extension. So that's sitting or standing and raising the leg. And wall squats. Does anybody know what a wall squat is? You do? My PT people? Okay, demonstrate a wall squat. Oh, perfect. Oh, you don't want to do a wall squat for me? no pressure. The key thing is that this is part of quadricep strengthening, and it can involve basically just using the wall for support and lowering yourself. The wonderful thing about isometrics is you don't overwork the muscle because it's what you can do. It's really based on what your body can handle, and you can ease into that, ease into the time that you spend in that. Ideally, the recommendation is to be at 90 degrees, make sure that the ankles are in line with the knees, and that you try to spend about 20 seconds in that position. My son, who's 18 and elite soccer player, can hold that for a minute. But for me, that would not happen. So you want to find that time, that interval that works well for you, and keep working on incremental development there. But you don't have to be an elite athlete to benefit from these, and you don't have to get your heart rate up to 180 to benefit from these type of exercises. So I just love that, and I hope that's an important takeaway. Exercises that work on balance, the key take home here is if you have balance problems, you need to work on it, okay? So improving stability with exercises like Tai Chi, like dance. I'll cover one particular comprehensive exercise that does a really good job at balance, Pilates. These help you to reduce falls, help you to reduce injuries related to falls. And you can do gait training exercises too, which essentially is a balance issue because you're shifting weight at a big speed as you're walking. So gait training exercises can be very helpful for improving balance while you're in static and dynamic movement. There are physical therapy members who can do gait training with you. And then also, think about if I've noticed there are some community-based exercise folks who help work with people on these kinds of things as well. And I'm not sure if they have PT certification, but maybe trainer at the very minimum. Flexibility is another part of exercise, really critical. Stretching is so important, and doing that twice a week really helps to lengthen that muscle, reduce injury and strain. And if you're in a good exercise program, they'll add stretching to it. Just try to make sure you do that piece too. And it should be before and after moderate, vigorous exercise. And sometimes when I'm thinking about my portfolio of fitness, I try to cover every aspect of my fitness, one component or another every day. If I'm really tired, if I've been working at the hospital, sometimes I'll just do stretching that day, and I know I've done something. So it's a great way to kind of sort of deconstruct the whole exercise plan by just trying to hit your targets around exercise from these various domains. And it almost doesn't matter what you do as long as you put the time in and focus. I started doing water exercises this summer because I have chronic knee issues, and I absolutely love it. So I wanted to share with you what is in the literature about water aquatic exercises. They're increasing in popularity. People are starting to realize that the seniors had it right all along, that we really need to try to find low impact ways to improve joint health and improve our cardiovascular fitness. And these classes are all over the city, as I've heard from patients and also in my own curiosity. High intensity to gentle movements like arthritis kind of exercises. And PT also does aquatic therapy. So if there's a particular injury you're working on, you can, be referred to a physical therapist to work on a particular back issue. There are a lot of other things can be well worked on from water-based physical therapy. And there are well-known benefits that there's less load on the lower joints. You can increase your extra energy expenditure. So that means that your aerobic fitness can improve because you're in the water, you're getting that support from the water. You can do a little bit more and endure a little better. And I find that when I do water fitness, I can do a lot more in the day because my joints are not feeling so worn down from doing, say a HIIT exercise. It reduces joint stress when you're stretching, and it can improve balance, and you can strengthen your muscles through natural resistance. So if I see you in the water, let me know that I talked to you about it and you came because of that. Last couple of topics that I'll cover before I leave time for the Q&A is brain health. And very important to think about that at all stages of life, but particularly when you're entering middle age into late life, really important to think about how to improve brain health by keeping your diet balanced, getting enough sleep, hearing optimization, is critical. That's a big gap that I see a lot in my patients. Regular exercise helps to boost those endorphins and keep your brain alert. Cognitive brain exercises, so that's a new hobby, trying something different from what you do in your normal day-to-day. Puzzles, learning a language. These kinds of things really help to stimulate brain activity. Controlling your chronic medical conditions. That's a critical part of brain health, because if your blood pressure is under good control, you're less likely to develop negative healthcare consequences result of poorly controlled hypertension. Appropriate medically indicated medications, and limit your alcohol intake to the guidelines. Managing medications becomes a really important topic as people get older, because more medicines are prescribed in middle-aged and older adults. So when you have a new medication added to your regimen, important to have a good understanding of what that medication is for, what are the side effects, what is the course of treatment, do I need to be on this forever or short term? Are there drug-drug interactions, and whether there are side effects you need to report to your doctor. I always advise keeping a clean, mean med list. Keep it updated and take it to your appointment so that your doctor knows what you're taking. And invariably, even for the most intelligent, thoughtful, organized person, when your pill burden gets too high, you invariably start missing doses and having errors. So using a pill box is important to stay organized. Pain medicine, I'll talk about just briefly. The important thing is to think about short-term goals with pain treatment. Over-the-counter medicines can be very helpful, but you really need to think about what the issue is that's being treated, and seek the help of a medical provider if you're continuing to need to use something for pain. Limit ibuprofen and NSAIDs, because they have a lot of side effects the longer you're on them. Stomach irritation, bleeding, can raise your blood pressure. And if you're on prescribed pain medication, you have to remember that those side effects don't tend to get better the longer you take it. You can still have sleepiness, confusion, and it can increase your risk of falls. And so acute pain management is really the way to focus. Prescribed opioids, et cetera, and for short-term use is really the way to go. Insomnia or sleeping medicines are also a really common medication that are utilized, and really important to be careful about how you're utilizing those too. I can address questions about that if you have further questions. So the last word is aging is associated with changes in physiologic function, but you can still optimize your health. And it's achievable at any decade of your life. Setting goals, working with your provider, connecting to resources that can help you with that can really allow you to live your best physical function life. And work with your healthcare provider through your annual visits and follow up for disease management around broader healthcare planning goals. This gets at what I was talking about related to healthcare maintenance. Integrate exercise into your life is a critical part of healthy aging, and balance your portfolio. And most importantly, have fun and become the example to your loved ones of how healthy aging can be done. So thanks for your attention. Take good care of yourselves. I can take some questions if you have any.
Oop, there we go. It's working. Thank you so much. That was a fantastic presentation. So thank you for being here and sharing your expertise with us. Before we get to questions, which I know we're almost at time, so I'll be quick. Slides will be sent out again. I know some people registered after the registration was sent to me, so you probably didn't receive them. If that was the case, though, they will be sent out to everyone who attended in person, online, all of that good stuff. And then in a few minutes, I will change the slide one more time. If you've been to one of these in the last couple months, you know we now use the QR code for the evaluation. So if you have your phone or want to scan the QR code, do the evaluation here, you can do that. I also will include the link in the email that I send out as well, so you can fill it out there if you prefer to do that. We had a few questions come online, so I'm going to do these real quick. I'm just going to sit down right here. This first one came on the slide regarding brain health, and they asked what hearing optimization was.
Oh, so that's if you have a hearing impairment, that you are improving your hearing, first of all, getting screened is critically important. And if there's clearly a hearing deficit, or a problem that warrants the use of hearing aids or some level of amplification, that you take care of that and get the necessary support for hearing loss.
Thank you. And then one more question online was, how does aging affect autoimmune disorders such as Graves, lupus, and Hashimoto's disease?
Well, what I really try to cover here are the most common elements of aging. And what I tried to sort of emphasize is that these are all they're what we call subclinical findings. They should not manifest in any problem that is present that requires a diagnosis. Now, if you have a chronic condition, that is happening at its own course, depending on how well it's controlled or not. And then you have normal aging going along with it. So it probably definitely has some large impact on aging health for patients who have autoimmune disorders. It's also critically important to think about pain management and optimizing function for that patient population. We use a lot more PT services for those types of patients. And it's a lot of support that you offer to try to help them to live their best lives. It's hard to generalize beyond that, but thank you for the question.
If we have any questions in the room, I'm going to run the mic to you. Would you mind clicking to the next slide?
Oh, sure.
Just so evaluations up there in case. I'll have you speak.
Are you familiar with the blue zones?
Tell me what you mean by that.
Yeah, so that's the area, we learned this in like one of our gerontology courses. It's about the areas of the world that have the longest living individuals, happiest, healthiest. There's a really great documentary on it now, and I just was curious, like you and your line of work, if that's something like you've come across, and would love to learn ways of us to incorporate it into kind of our daily life.
No, that's a wonderful question. I think I imagine America is not a blue zone. So we got some work to do. And I think part of it is that I think, we have in our culture, it's important to really change the way that we think about aging and really focus on the value and the tremendous strength that seniors can offer in our workforce, in our communities, and within our families. Of course, they're central. And so I think that that attitude hopefully will shift as our baby boomers are moving into their late ages and have a different perspective on health and quality of life, and then demanding that things be present in our communities that can really help to improve aging. As I was putting this talk together, I thought a lot about what are the things that exist in the community where I live that can optimize healthy aging. And I think, even though I think there's a lot that's there, I think there's things that could be improved upon. The silver sneaker benefit is very important for Medicare beneficiaries. It helps them to access gym and exercise programs. That is typically available through like the YMCA and a lot of other private clubs that allows seniors to get into gyms and use a lot more services there. I'm not sure how that Medicare benefit is dealing with some of the challenges that gyms are having after COVID and trying to maintain their bottom line. But I think those kinds of public policy initiatives can really help to optimize aging for every individual, because we want to make sure that there's no health disparities or differences in that. So thank you for the question.
Have any more online? I know we have some online, but any more in person? Nope. And I echo what the question asker said, the blue zones. We've looked into that a little bit and familiar with it. It's very interesting. Would encourage people to look into it as well. Okay, so we have 2 questions online, so we'll do these 2 and then we will close it out.
Sounds good.
We're almost at the time. When do we need to start cognitive evaluation to monitor/prevent memory loss?
So the general recommendation is that it's kind of what we call a part of the Medicare benefit. So there's a Medicare Wellness exam is done. So an older adult who's Medicare eligible is 67. So we do screening at that point in clinic. Every primary provider has to have some skill in being able to screen for memory loss because the incidence increases after mid 60s, and the prevalence tends to increase every 5 years from that point. So screening is critically important at a certain age point in an older adult's life because late onset memory loss or memory difficulty is quite prevalent. In younger, older adults, it's not quite that extensive in terms of how the cognitive evaluations go. If you have an issue in young adult life, either with having a head injury, a stroke, any of those medical conditions that might affect brain function, then it stands to reason that you having cognitive evaluation early would be important. If there's a familial history of Alzheimer's at early onset, so this is less than the age of 65, 45 in some cases. There are some patients who have Down syndrome who have Alzheimer's disease quite early as well. So there are certain patient populations where early screening is highly recommended and is a part of their routine care. For sort of a general recommendation around middle to young adults, there's not a clear guideline on that. Really, it's dependent on what the clinical condition is.
We have one more question online if you have time.
Yeah.
This last one is asking, when you reach a certain age, should you change from a regular primary care doctor to a geriatricist?
Geriatrician. Yeah, that's me.
I'm sure that's what they meant.
I know that word well. Yeah, so I would say that that's a very important question. We have a dearth of geriatricians in the United States. There's not a lot of practicing providers. We tend to be very localized in urban communities near academic centers. So Ohio State has a good number of them, and you might be able to consider that for yourself in your care planning down the road. In some areas, rural areas, and some areas where it's more suburban or community hospitals, there don't tend to be a lot of geriatricians there. So often what our society, the American Geriatric Society, has tried to communicate is that everybody needs to learn these skills. We try to convey that there's a core practice and training that's critical. And so your providers who are nurse practitioners or physicians who have had some training will have had clinical training in geriatrics. We tend to get referrals, though, when there's additional concerns around some of the conditions or syndromes that are very common in older adults, like memory loss, falls, problems with balance, problems with living independently. So it doesn't hurt to try to reach out, but when it's not available, then you have ways that you can seek that kind of support through your primary care provider first, and then they may be able to help you identify a geriatrician later if that seems appropriate. But thanks for your interest.
Thank you so much. And with that, I know we're a little past the hour, so we can close it out with that question. So thank you so much again, Dr. Ray, for being here. This was fantastic.
Thank you.
And thank you everyone who attended. Be on the lookout for the slides, evaluation link, and all of that good stuff will be coming your way. So thank you so much. Have a great weekend and go Buckeyes.